Now I'd like to introduce our next speaker. Dr. Arash Asher has served as the Director of Cancer Survivorship and Rehabilitation at Cedars-Sinai since 2008. He has a special interest in the physical and rehabilitative needs of cancer survivors who continue to experience the effects of their cancer or its treatment. Dr. Asher has led the development of several unique cancer survivorship programs with his colleagues, including Emerging from the Haze, GRACE, and others, with the goal of optimizing physical, psychological, and spiritual resilience for patients with cancer. Dr. Asher completed a cancer rehabilitation fellowship at MD Anderson Cancer Center in Houston, Texas. Please welcome Dr. Asher.
Thank you so much, Myra. I very much appreciate the introduction. I appreciate the opportunity to be with you. Even I wish I could be doing this in person, but I'm glad we have the technology to allow us to connect virtually. So this is one of my favorite topics in thinking about how we can try to think outside the box in creating wellness and survivorship programs. So we entitled this presentation, Creative Strategies for Building Inclusive and Whole Person Survivorship Care. By way of introduction, just very briefly, I want to highlight what I imagine are some of my goals in my remarks. So number one, thinking about how really, even though I'm not a psychologist, and I often confess that at the beginning, I do believe that a lot of the distress that our survivors experience, at least in part, stems from psychological distress. I'm going to go over some of the various etiologies implicated in cancer-related cognitive impairment, of course, commonly known as chemobrain, and thinking about the role of social determinants of health for one of many common survivorship concerns, but I'm going to highlight cancer fatigue as kind of an example. And I'm going to spend a fair amount of time thinking about how the way we live our lives and our lifestyle, how that can improve many of the symptoms that survivors might experience. Okay, so by way of introduction, I am fortunate to be part of a much larger team. We call this the Patient and Family Support Program at Cedars-Sinai Cancer. Dr. Irwin is our medical director. But I'm going to really focus in on this arena here. Again, some of the things that we've worked on our team through the wellness, resilience, and survivorship facet for this larger program. And many of you may be aware that one of the landmark publications that came out around 2007 was from the Institute of Medicine, From Cancer Patient to Cancer Survivor, because at the time, there was finally increased recognition that when one is done with surgery, chemo, and radiation, for many of us, the existential and psychological and physical issues really come to the forefront when you finish active treatment and you're trying to integrate back to your roles in society. And so this book really highlighted the myriad of issues that one might face, from physical issues like pain and neuropathy and musculoskeletal issues and fatigue, to psychological and psychosocial issues. Of course, I'm not going to go through all of these, but I'm going to try to highlight some of our programs that were meant to address some of these concerns. And I just want to share, I guess, my biases, right? I think we all have biases, but these are, I guess, the fundamental ideas, quite simply put, that I think has really helped guide me over the years. So number one, I think we have a really fundamental job in as healthcare providers, which is, number one, we should either be doing things to help our patients live longer or to live a better life or have a better quality of life. And I mention this because it seems obvious, but a lot of times we still may be doing things in healthcare just for the sake of doing things that when may not necessarily be helping our patients live longer or better. And I think it's really important to challenge ourselves to make sure that we are following one of these two ideas. And the hope is that we really have both, that things that will help us live better will help us live longer and vice versa. My second idea was that I love yoga programs. We have a yoga program. The Cancer Supported Community Programs has great yoga programs and mindfulness programs. So I think they're wonderful. The evidence behind them is irrefutable at this point for a number of outcomes, but I don't think they're necessarily for everyone. And so I think it's worth broadening the menu of options that are made available to our patients. Whenever feasible, I think it's important to straddle a research question so that we can improve the science. And another basic idea is the following, that the types of things that we think about on a consistent basis and the kinds of behaviors we engage in, the disciplined actions that we take on a day-to-day basis really will shape our health in the long run. And that idea was really echoed in a really beautiful quote I want to, again, start with, and this is from Wilfred Peterson. And I think this really speaks to the idea of neuroplasticity, which is so important to many of the issues that we're going to be confronting in cancer survivorship. So this is what Wilfred Peterson said. As a single footstep will not make a path on the earth, so a single thought will not make a pathway in the mind. To make a deep physical path, we must walk and walk again. To make a deep mental path, we must think again and again the kind of thoughts we wish to have dominate our lives. And I think that really speaks to the importance of, again, the kind of programs that we try to offer, which is not just meant to treat a physical symptom, but really change how we are engaging with life and the kinds of behaviors and thoughts that we're bringing to this space in cancer survivorship. So I'd like to start the story with thinking about cancer fatigue and the role of exercise in medicine. And as many of you, I imagine, are aware, fatigue in many studies is felt to be the most common and for some the most distressing of side effects of treatment. And if you look at, for example, breast cancer fatigue, it seems that like a third or so of our survivors continue to struggle with fatigue months or years even after the treatment has ended. But there's a lot of variability. And that's where I think some of the research that we've been able to do with Julie Bauer, UCLA, has really helped give us some more insights on why is it that some people bounce back, but some people struggle with fatigue for these protracted periods of time, even when their treatment is ended. And for Dr. Bauer and her team, one of the first insights was a small study they did with breast cancer survivors who had fatigue and those that did not have fatigue. And what they found, and this was, again, a small study, but what they noticed is that the group that had persistent levels of fatigue, it turned out that when you looked into their past, into their childhood, they had a much higher likelihood of undergoing emotional abuse, physical abuse, sexual abuse, unstable homes, conflict, parental divorce, whether it was perceived or not. If they perceived these adversities to be real, it seemed like they had a higher likelihood of having much higher levels of fatigue. So again, giving a clue that what might be happening to us before, right? Before we ever had our breast cancer or cancer experience may be impacting how we are going through this. And so the theory was that somehow that adversity, let's say in our childhood or in our teenage years or early adulthood years, somehow primed our immune system such that when you go through surgery, chemo, radiation, for example, that there's a magnified inflammatory response that may perpetuate certain symptoms like fatigue even after the treatment is gone. At least that was the theory. And that was really one of the underpinnings of this large study that we participated in with Dr. Bauer. So one of the things we looked at is, okay, we know that people who have fatigue at the very beginning, so before their chemo and radiation starts, seems to be a predictor for who's likely to have more fatigue afterwards. One basic question is, okay, well, who are the people that are more likely to have fatigue before chemo radiation? And there were a few common themes. And number one, if you're younger age, again, lower socioeconomic status, again, reflecting to our upbringing, seemed to be a risk factor. A history of, again, depression or a childhood maltreatment, again, earlier in life. And again, this is all important because if we believe that pretreatment fatigue is the strongest predictor, or at least one of the strongest predictors, it's important for us to pay attention, right? Because if we can identify these patients earlier on, we can intervene. So the next part of the study is we actually followed these patients throughout their treatment course, right? To see, what kind of patterns emerge for fatigue, at least among people with breast cancer. And and I don't want to spend too much time on this, but one of the things you'll notice is that there are a myriad of patterns. And one of the reassuring features of this study was that for most individuals, you either started low and ended low. This is the stable low group, or maybe you started high because you had a lot of distress and fatigue after getting the diagnosis, but then things improved, or maybe it went up with chemo and radiation, it comes back down. So that was reassuring, but there were a couple groups that stayed high or went high over time, the increasing group or the so-called stable high group. And again, it was important to try to figure out what was it about this subgroup so we can try to help these people. And it came down to a couple of findings from the study. Number one, the stable high group was much more likely to have depression prior to their diagnosis. And almost everyone, 97%, had a significant sleep disturbance. So having a history of depression and a sleep disturbance may really set the stage, right? It may really prime us for having more persistent levels of fatigue. And so the conclusions was that we used to think a long time ago that, maybe chemotherapy A or certain chemotherapy drugs may make you more likely, and we weren't able to differentiate that. So that was one important conclusion, that fatigue levels truly are variable. And thankfully, many people do well, but if we could identify the people that are more likely to struggle, including this idea that if you have fatigue before your treatment starts, there's an 80% chance that it won't recover within 18 months after the treatment is ended. And rather than waiting months or years to finally attend to these folks, I think one of the lessons from this study is we want to reach out to these folks earlier, especially if they've had depression, distress, sleep disturbances prior to their diagnosis. So if we do identify these folks, then the question is, well, how can you try to support them? And I also believe, and this evidence is shown, and this is from the American College of Sports Medicine. This is, I think, a really lovely infographic on the value of exercise for including having strong levels of evidence for cancer-related fatigue. And it kind of breaks down, I'm not going to go through the details on how much aerobic exercise, how much resistance, how much of the combination ideally do you want to get to really optimally manage fatigue. And it goes down and offers suggestions for anxiety and depression, sleep, etc. But exercise, we know, is helpful. The question is also why. And there was a nice study from a few years ago that kind of went through all the myriad of mechanisms that attempted to maybe explain why exercise can reduce fatigue. And I'm not going to go through all the molecular pathways. A lot of them had to do with basically inflammatory compounds that are reduced with exercise. But since I know I'm speaking to many therapists, psychologists, social workers in the group, I really want to highlight one facet of the mechanisms discussed in the study, which I highlight up here in red, which is this idea of self-efficacy, right? So exercise improves self-efficacy. And again, I know I'm speaking to a group of therapists, so you know what self-efficacy means much more than I do, but just to get us all on the same grounding, right? Self-efficacy is this idea that we believe we can achieve our intended results, right? And we know that self-efficacy is associated with improved resilience and improved well-being. And what was interesting to me, what we've seen with our own exercise program here at Cedars-Sinai, is while there are many methods by which one can improve self-efficacy, I now know, and the evidence has shown, that exercise can meaningfully improve self-efficacy. And there's basically 4 mechanisms by this. Number one, you're having mastery of an experience. And so our patients come in and they could maybe do 5 minutes on the bike. And if they could do 20 by the end of the program, they've mastered a new experience. If they can do 5 push-ups and end with 25, they've mastered an experience. There's social modeling, right? So you'll see other participants in our wellness gym. And so if you kind of say that Mary can do this, then that may improve our sense of self-efficacy. And social persuasion, this is the job of the trainers and the exercise physiologists, where you're being cajoled to kind of push yourself and improve your fitness level. And of course, the endorphins that are produced, right? The psychological response from exercising. So exercise, I believe now, is just one example of how we can gain self-efficacy. And it seems to be an important mechanism by which exercise improves cancer-related fatigue. So the bottom line, all survivors should be counseled regarding the benefits of exercise. And it seems that we should aim for at least 150 minutes of moderate aerobic exercise. This amount is not only associated with improved fatigue, but even all-cause mortality for a number of cancer types, including breast, colon, and prostate cancer. This is echoed by virtually every major national organization. And despite all of these benefits, the challenge is that when you look at national studies, women decrease their activity by 2 hours a week after a diagnosis. If you look at women treated for breast cancer, 3 years after the treatment is ended, it's as if they have aged 20 to 30 years in terms of their cardiorespiratory fitness. And again, this is important because exercise can potentially reverse or mitigate this. And one of the reasons I take the opportunity to talk about this in every venue that I can is that studies show that 10, 20, 30%, this study was 21% of survivors recall having any discussion about the benefits of exercise with their provider. And so I don't think this is the role of just the oncologist or just the surgeon or just the rehab doctor. I think anybody that works with cancer survivors has an opportunity to at least give some basic counseling on the value of exercise in cancer survivorship and well-being. So one of the programs we developed is our Cancer Exercise Recovery Program, which is a 3-month intervention where we really individualize and tailor this in terms of the type of exercise, the intensity, the duration, and we have a little gym, and so we kind of run this program in our wellness gym. But one of the things that has not been looked at in the cancer arena is the environment, right? So we said, for example, 150 minutes of aerobic exercise we know seems to be helpful, but where we do the exercise and whether it's like a busy urban area, is it on Wilshire Boulevard or La Cienega near Cedars, or is it in a gym, or is it in a green space? Does that make a difference? And so we are in the midst of a pilot study to try to at least gather some preliminary data to see if it's feasible to convince our breast cancer survivors to come to a nature preserve and do a 3-month moderate intensity walking program. And we're really looking at not only how this impacts our well-being with patient-reported outcomes in terms of anxiety and depression and fatigue and distress, but also biologically, how is this impacting us, right? How does this change things like DNA methylation, which is implicated in biologic aging. How does this change our inflammatory markers, which we know is important for cancer survivorship and a number of important outcomes. So the hope of doing all this is once we finish this pilot study, is the next thing we hope to do is put this to the test, right? Create a randomized clinical trial where we keep all the variables the same. So you're going to do the same amount, the same duration, the same frequency, the same intensity of exercise. The only thing that would change is you'll be in either one or two spots. You'll be in a green nature preserve, or you'll be, let's say, for example, in a gym. Will it make any difference? Is it just the exercise, or is there something possibly advantageous about being surrounded with trees or in nature in the sunlight? And we'll see. We'll see. Obviously, we don't have the answer quite yet. Okay, so I'm going to shift gears a little bit. The next topic I'd like to talk about is another common and important one that I contend with on an almost daily, weekly basis in our clinic, which is so-called chemobrain. And I'll explain why I have this in quotes in a second. And I imagine, of course, if you work with our cancer survivors, you'll see this. People will describe their short-term memory problems. It's harder to concentrate, to attend. There's a word on the tip of your tongue and you just can't get that word out as easily. It's harder to multitask. It feels like our brains are working just a little bit more slowly than before. And again, for some people, this can be really distressing. The reason why many will argue that we should redefine chemobrain is this idea that there's no single symptom, one that defines this. And there are many people who never even had chemotherapy, right? They may have just had surgery and radiation, or maybe surgery, radiation, and hormonal treatment with like things like tamoxifen or Arimidex, or if you're with prostate cancer, testosterone blocking drugs, and still experience those symptoms that we talked about. So the medical term that's favored now is called cancer-related cognitive impairment. And whatever you call it, at the end of the day, we have to strategize ways of trying to improve this symptom. And unfortunately, we do not have any great evidence for any drug, right? So there's been a number of medications like methylphenidate or Ritalin, modafinil, ginkgo biloba, and a few others that have been at least studied in various sample sizes. And there is no good evidence that a drug in and of itself will solve the myriad of issues that we were describing. So if you look at the NCCN, right, one of the major oncology guidelines, they'll have a busy kind of guideline telling you all the different things that we should try to do, such as, let's say like teach enhanced organizational strategies, or provide information about stress management, and consider some mindfulness training, and on and on and on. And the point I always make is, if you're a busy clinician, it's almost impossible to kind of go through all this in a clinical visit. And so what can we do to try to package this and other ideas that can improve your cognition in a way that is digestible to our patients? And so we developed what we call like a roadmap to brain health and wellness, where we kind of fleshed out what we thought were important topics like mindfulness and stress management, and thinking about all these lifestyle factors that seem to be implicated in cognitive performance, and some of the cognitive strategies that are important that our neuropsychology colleagues really have been taking the lead on. And we created our own curriculum, and the program we call Emerging from the Haze. And this is now a 10-session program where we package all these different strategies. Usually sessions are about an hour, maybe an hour and a half. And our patients or participants are given kind of homework assignments to reinforce some of the key ideas and strategies. And so we did put the program through a clinical trial a couple of years ago, where we compared those who went through the program in blue and those who were in the waitlist control in red. And basically with the FACOG, this is an assessment tool that measures chemobrain type symptoms, the higher the score, the better quality of life. And thankfully, we were able to show that those who went through the program improved and seemed to have maintenance compared to the control group in red. And so that was nice. And we, when we did the study originally, we had people come to our conference room, and we're doing this program in groups of 10 or so in person. And then, of course, March 2020 came, and of course, all group programs came to a halt. And so we kind of pivoted, like you all have, and tried delivering the program in a virtual context. And I'm not going to read you this whole poster that we presented because it's too busy a slide, but just to highlight the key points, we found that, at least in this pilot study, that even a virtual delivery, so we still had 10, 15 people in the group, but they were all in a Zoom platform like we are now. It was feasible and acceptable, and we were able to show that there were improvements in kind of those patient-reported outcomes that are important for chemobrain type symptoms. But there was another important facet that we learned, that both from our original study and this study, that feeling lonely seems to be another important predictor. And I think, especially as we're talking about social determinants of health today, I just want to highlight this facet because it seems to be in our work, and I'm not highlighting all the studies that we did in this space, that loneliness at least seems to be associated with higher cognitive symptoms, probably because of the stress and distress response that's associated. And so encouraging our patients to feel connected and reminding them that they are not alone. And I think that's what a group type program may offer, reminding them that they're not the only ones, right? There's that they could be part of a tribe and a community that's learning how to navigate through this together. That may be as important a part of the recovery as any. So again, we did this group, whether it's in person or virtually, groups of 10, maybe 15, 12 or so. And then when you think about the number of cancer survivors we have across the country, right? I think currently estimated around 17 million. And if we believe the statistic that maybe a third of them struggle with some kind of chemobrain type symptoms months or sometimes years after the treatment has ended, there is no way, right? There's no way we can touch that many people by doing this group 10 to 15 people at a time. So we were challenged to think a little bit more broadly and think about, how do we effectively disseminate these kind of interventions for a common concern, such as, cancer-related cognitive impairment. And so one of the ideas that we were kind of, and this is not something I ever thought I would get involved with, but that we kind of came across was, creating a standardized video product, right? And this is what, this picture was meant to show, that we were in this room. My colleague, Dr. Jeffrey Wertheimer, our lead neuropsychologist, who co-facilitates this with me. We were in this room for, I think, 3 days, all day and all night, just recording the content. And we packaged it to kind of make it uniform and standardized, so then it could be distributed, in different sites across the country. And that's basically the study that we are towards the end of right now, where we're enrolling patients with different types of solid tumors, Hodgkin's or non-Hodgkin's lymphoma. They've completed their chemo at least 6 months ago, and they're going to get randomized into one or two groups. Either you watch the live group that Dr. Wertheimer and I are doing, or a pre-recorded version that some other facilitator at a local institution, whether it's a social worker or a therapist or a speech therapist, is still facilitating, but the content is still all standardized through the video or with its control. So we're still recruiting for this study. Hopefully we're going to finish in early 2023. And again, I hope that if this is successful and our interim analysis has suggested that, our next goal is then to translate this into Spanish, right? We're going to dub this program into Spanish because we know, to the best of our knowledge, there is no standardized intervention at all for our cancer survivors who are primarily Spanish speaking. And so that is another important opportunity that we're trying to get support for creating this new product, hopefully in early 2023. And I would argue the other group that often does not have access to this kind of care is our rural population, right? So I'm working with Dr. Jamie Myers in University of Kansas. There are many of their patients that live 50 miles, 100 miles from a cancer center. They can't come to these in-person groups. So again, seeing how we can make these programs more accessible to people who live in more rural communities is another important goal for this kind of study. Okay, and I'm going to shift gears, I think, for probably the last topic that I'll have time for. And this is a program I worked on with Dr. Wertheimer after we kind of had the HAZE program rolled out. And I should say, a lot of these programs, the reason we worked on them was out of a need, right? These were patients I was seeing in clinic, and we were looking for kind of other strategies to try to support them. And so the GRACE program, in essence, was meant to address the huge issue of existential and spiritual suffering that many of our patients experience, right? Whether it's any of these facets that you see here, being preoccupied with the past or future, feeling disconnected, feeling like we want to be in control, but this sense that all our control has been stripped away from us, or this existential vacuum that some patients experience. And so as we were thinking about how to kind of frame this program, there were three fundamental questions that at least preoccupied my mind in terms of working through the content, which were, number one, what does it really mean to be healthy? And I know this seems far too simplistic, but I think what happens to many of our patients is our definition of health is really determined by what your CT scan report shows, what your tumor marker reports are they going up or are they going down, what your blood test is, what your medical report is, right? If the CT scan is good, I'll feel healthy. And if it shows something else, I won't feel healthy. And I think if we're really going to try to optimize well-being in a holistic way, we need to think about health in a larger way. What does it really mean to be resilient? And what does it really mean to be fulfilled? And as a physician, I apologize, the ambulance driving by. As a physician, I prescribe antidepressants, I prescribe anxiolytics. I think they play a very important role for a number of our patients, but I do not believe any longer that any medication in and of itself will answer these fundamental questions about living and therefore suffering, which almost invariably exists at some point in our lives. So I personally was inspired by Dr. Viktor Frankl. I imagine many of you are familiar with him. He wrote a very important book called Man's Search for Meaning. He was a Holocaust survivor and a psychiatrist that between the years of 42 and 45 was imprisoned in 4 camps, including Auschwitz. He lost virtually everyone that was important to him, including his pregnant wife. And he suffered. I mean, I think that part is clear. He clearly did suffer. But he observed as an observant psychiatrist that while suffering was omnipresent in the concentration camps, he kind of noticed that, some people seemed to survive camp life better than others. And what he noticed is that those people that had a sense of meaning, a purpose, some hope, something to live for, seemed to survive the horrors of the camps with some resilience more than others. And his argument was that if you could find a sense of meaning and purpose in any of these 3 domains, and through your work, doing something significant, through acts of love or acts of caring for another person, or through cultivating a sense of courage, particularly during difficult times, that any one or a combination of these ideas was really critical to living and trying to rise above the challenges that may occur when we're really going through significant challenge and significant suffering. One of the other questions he beckoned his readers to consider is to try to ask ourselves this question: what does life expect from me, rather than what the reality is most of us do, is what do I expect from life? And of course, there's just a subtle shift in the sequencing of words here, but I think you'd agree that the implications of these two different questions couldn't be greater, right? What does life expect from me, rather than what do I expect from life? And the first question, of course, brings up a lot of responsibility, right? And that's what he talks about often, is our responsibility in how we're going to respond and manage the situation that we have in hand, rather than what do I expect from life, which is, maybe more kind of pleasure seeking and maybe a more hedonistic perspective. And I think what most of us, including myself, probably grew up expecting with our upbringings. And so I remember reading this in Frankl's book a number of times, and then I came across this really fascinating study, and maybe I could just go through this very briefly. So this was a study looking at two groups of individuals. It was one group that was felt to be strongly hedonistic, and you all know what that is, right? Somebody that's primarily more pleasure-oriented, right? So and so maybe, if you're at a cocktail party, this is the person that is there for the wine and the music and the nice lights and nice kind of ambiance and whatnot. And versus a eudaimonic outlook, which, if you're not familiar with that term, is more kind of oriented to this idea of virtue or service or community and doing meaningful things. And so what they did in this study, very simply, is they took a group of adults who were all happy. So on these kind of patient-reported outcomes, they reported high levels of well-being, but you were either very strongly hedonistic or strongly eudaimonic. And then what they did was they compared their inner biology. So they had blood samples, and I'll walk you through this. This is where I think things got really, really interesting. What they found, and I'm going to focus on part B for the sake of time, was the hedonistic group had higher levels of pro-inflammatory cytokines, right, which is associated with more of our chronic health problems. And they had lower levels of antibodies, which we all know is important for our immune system and how we ward off infections and whatnot. And it was basically the reverse in the eudaimonic group. They had lower levels of inflammatory cytokines, and you could see markedly higher levels of antibodies. And so when I saw this study, I couldn't help but think about, again, Frankl, right? And Frankl said, stop asking yourself, what do I expect from life? And try to ask yourself, what does life expect from me? And his argument was, remember, he observed many, many years ago that the people that had a sense of meaning and purpose seemed to live more in this what does life expect from me viewpoint. And he argued that they somehow seemed to survive life camp better. They were less vulnerable to dying from, let's say, infectious illnesses that were rampant in the concentration camps. And I couldn't help but think that, again, maybe this change in your biological profile, right? You have higher levels of antibodies, maybe, and it's just a guess on my part, maybe that was part of the secret sauce that enabled, however difficult these people to survive camp life better. So kind of influenced by Frankl, and I don't have time to introduce her at all, so I was deeply influenced by Dr. Rachel Remen, who wrote My Grandfather's Blessings and Kitchen Table Wisdom. We developed a 6-week program that kind of centered around logotherapy, cognitive behavioral therapy, positive psychology, mindfulness interventions, and a number of kind of process-oriented experiences. And so we developed this curriculum called that we call the GRACE program. And this is just an overview of the program that I'm not going to belabor right now. But the basic pearls that we go through is thinking about, however difficult it may be, meaning-centered living, and trying to introduce strategies in which we can do this, trying to help our participants master a sense of perspective without being a Pollyanna about things, trying to integrate a sense of gratitude through gratitude journals and exercises, thinking about a sense of legacy, which means thinking about mortality. But that is one of the paradoxes that we dive into a fair amount. Is there are many that would argue that if we're going to live as well as we want to now, that we have to wrestle with the idea that all of us are mortal. And the importance, remember we talked about loneliness, the importance of staying connected and trying to create and foster community, mindfulness strategies, and again, strategies to try to integrate humor into our life. So we did this program for a while, and we finally realized we should put this to the test, and we were fortunate to get a grant to support a randomized clinical trial where we took women with metastatic breast cancer and enrolled them into the program, the intervention or waitlist control. And again, I was very fortunate to collaborate with Dr. Wertheimer and our chaplain Bronwyn Jones in running the program. And again, thankfully, without going through much detail, these are two common scales for quality of life: the facet spiritual scale and the FACT-G, which is an overall quality of life scale. And the higher you are, the better quality of life. And so what we found is compared to baseline, the group that went through the intervention had meaningful improvements that were maintained over time in both these parameters, and the control groups remained relatively flat. So one of the things that we realized we need to address, though, and this is a table from the study that we're actually submitting right now for publication, is when you look at the some of the detail, the vast majority, right, like 86 to 90% of our participants were white, and they were very well educated. And again, we still need to contend with the same basic idea of, how do we make these kind of programs more accessible to a more diverse group? How do we maybe translate this into other languages and make this more accessible? That's something that we do have to tackle on next, and certainly much more work needs to be done. Okay, and so I realize I'm getting close to 3:15, so I'm going to not discuss our improv program. It's on hold anyway because of the pandemic, because we can't do an in-person group-based program, which is really what you need to do improvisational comedy. But we hope we can relaunch this in the future. And I'm just going to round things out with just an overview of some of the programs that we have. We're lucky to have our exercise program that I mentioned. Yoga, we of course collaborate. We're lucky to collaborate with the cancer support community for Qigong. And I mentioned our GRACE program and our HAZE program. And like many others, we have an art therapy program, and more recently, we were able to launch a kind of cooking demonstration program. Our social work colleagues thankfully have started a sleep program and a mindfulness intervention. But I list all these things because it ultimately, in my mind, goes back to what I started with, which is, if you notice, none of these interventions, involve drugs. And I'm not saying that there's not a role for a medication, but again, going back to at least what is my personal bias, that the things that we think about on a consistent basis, and our behaviors and our disciplined actions that we take on a day-to-day basis, I think in this space, in the cancer survivorship space, probably makes a more meaningful impact than whatever the drug du jour is. And so that at least is my bias. I'd love to entertain any feedback, comments, questions that you may have. And again, thank you so much to the cancer support community for inviting me and giving me this opportunity. Thank you.
Thank you so much, Dr. Asher. I mean, that was an amazing presentation. And I think what I'm going to remember from this, because it's so shocking, is that 3 years after cancer treatment, you can age 20 to 30 years in cardiac fitness, right? I mean, it was so shocking to know that number. And I think if more people, knew about it, like you said, if more providers spoke to their patients about the importance of physical activity, I think you would see more cancer patients moving, right? Because that is pretty shocking. And so my first question to you, Dr. Asher, is, exercise is one of those activities that's difficult to fit in, right? People say, I don't have the time. And I mean, it kind of sounds counterintuitive to say, I'm suffering from cancer fatigue and you're expecting me to move, but I'm too tired. So, but it's also one of those things where you can see the immediate results and feel better, right? Immediately. So what do you say to those patients who say, what, the fatigue is too much? And, I have, a million things to do. I'm taking care of my family. Maybe I went back to work. How do I make sure I make physical activity a part of my daily life?
That's a great question. And I kind of think about that in a practical level and, maybe just a more kind of philosophical level. So on the practical level, I think it's really important to have some kind of structure because, right, when somebody's so profoundly tired and somebody is just telling them to get some exercise, I mean, that could almost be insulting to that individual. And so one of the reasons why, whether it's a physical therapist that's experienced in working cancer survivors, or if you have access to a structured type of program like we mentioned in our exercise program, is when somebody is there to assess where you are at baseline. Right, and let me explain things this way. So I'm going to take a step back. This is going to take a second, but I think it's important. If you look at the recommendations that we talked about, it said 150 minutes a week of moderate aerobic exercise. Now, what's moderate, right? Because what's moderate for like an Olympic athlete and what's moderate for Mr. Jones is going to be two totally different things. And so one of the things that happens is people hear that thing, get 150 minutes of exercise, and they'll say to themselves, okay, I used to, I'm just making this up, jog 3 miles 3 times a week, and it was very moderate for me. And I'm going to try to go back to my previous regimen. But what used to be moderate for me before the surgery, chemo, and radiation today may feel like training for a marathon, which is going to probably make you feel worse and more tired and more aching and whatnot. So resetting what is moderate today is what we need some guidance on. And that's where our trainers and exercise physiologists can really help guide so that it becomes more gentle. The other part I would just say is it's having some kind of accountability with whether it's a friend, a neighbor, a group, a class, a trainer, that really makes a big difference. It's really hard to start this unless you're incredibly disciplined, which some people are, but I would argue many of us have a harder time. However way we could facilitate that accountability, I think is half the battle.
Yeah, the who keeps me accountable is my 2-year-old puppy. Because if I do not walk her every day, she will make my life miserable and will not let me work. So, I mean, it's a huge motivator for me to get moving. And I know the other thing I did is I put my Peloton in the living room. So it's a constant reminder. So the days I feel like a couch potato, in the corner of my eye, I can see my Peloton. I'm like, ooh, I kind of should be moving, right? And so thank you for talking about that. And the difference in terms of, like you were saying, moderate exercise, and it's really your rate of perceived exertion, right? At what level? And so I love that you're mentioning that, because I think all of us think we should be working to the point where we can't breathe, where, you're about to faint, you're sweating like a marathon runner. So thank you for really, bringing that up. I think it's a great reminder.
And I would
So,
just say, just really briefly, if your patient is trying to grapple with that, pragmatically, what that means is if you can sing a song, you know, the whole time, you have some room to maybe increase the intensity. But if you cannot speak in a sentence because you're huffing and puffing, then you know you are in the intense zone, and we can slow that pace back. So moderate means you should be able to talk in a brief sentence, and that could serve as a kind of practical guide.
oh, that's wonderful. Thank you. And we have a question from one of our attendees. They're asking, what are the benefits, if any, of receiving speech and language therapy from speech language pathologists for chemobrain?
Great question. So the program I mentioned, Emerging from the Haze, is obviously a group program. It's not tailored, right? And we know that when, for example, a patient with these cognitive symptoms maybe has neuropsych testing, you know, a neuropsychologist will delineate how someone is doing in terms of their attention and processing speed and visual memory and other aspects of cognition. And so I think a speech therapist would be an ideal partner to tailor that kind of rehabilitation based on that individual's strengths and weaknesses. And of course, they have the advantage of working one-on-one with a person on their goals in a way that we can't offer in a group type program. So I'm glad somebody brought that up. I love to use our speech language pathology colleagues, and it's made a big impact. And again, people hear the word speech therapy. I mean, our lay community, and they don't realize that a big part of their role is offering cognitive rehabilitation strategies.
Yeah, taking advantage of all the services that are available, right? Something we're not used to seeing as part of our care team. And I think that that's a great question. So whoever posted that. Now, our next question, Dr. Asher, is to what degree are patients you work with open to the posture of, what does life expect from me?
So that's a really hard one. And I didn't really mention this when I was mentioning our GRACE program. We try to be very careful about, as best as we can, in who we invite, because let's face it, many individuals just don't want to go there. Maybe they shouldn't go there. It might be too triggering. The wound may be too raw. We usually, as a general rule, tell individuals that if you were just diagnosed within the last 6 months, you should not consider this program, because again, it's too raw to be thinking about these things. But then on the other hand, I think there are a number of individuals who have gone through this life-changing diagnosis. They may have overcome many of the physical, right, challenges, but that existential piece is still something that they want to wrestle with. And if we could try to figure out, who is that subset of individuals that is really interested and maybe has the introspection of wanting to contend with these really more profound ideas. I think in my experience, for those individuals, when you expose them to these ideas, it could be profound in terms of how much of a shift it can offer, and again, how we're seeing our world, how we're perceiving our relationships and the important things in our life.
Thank you. And, one other question I have, and I know you brought up, it's all the things that, are affected by cancer treatment or just the cancer diagnosis. And you brought up things like DNA methylation. And I know some of the recent studies are also showing that for some survivors, the treatment is also causing insulin resistance, right? And so some of the patients are gaining weight. And so they're looking for ways, to be physically active to combat that. So I was wondering if you could speak a little bit more about that with people who are, we're telling patients, try to maintain a healthy weight to prevent the recurrence and move. And so now there's something else they have to contend with, and sometimes it's this insulin resistance.
It's a big challenge because sometimes the hormonal drugs that individuals have to take for a number of years may be contributing to that. And it's not something that is advisable to stop. I didn't spend much time talking about this. I do think aerobic exercise is important for insulin resistance. I'm believing more and more as I dive into this topic that learning to lift heavy things, when I say heavy, heavy for you, right? I don't want anyone to hurt themselves or make sure that we don't have poor form, but really developing muscle mass with what my favorites are the squat, the deadlift, military lift. I know historically all of the attention has gone on just aerobic exercise, but developing muscle mass seems to be another important mechanism for insulin resistance, number one. Number two, and again, I would never advise anyone to do this on their own without making sure they have appropriate supervision or clearance. I believe now that all of us, but especially for people that are trying to address insulin resistance, should sprint every 7 to 10 days. And again, there is a learning process in how to sprint safely. And whether the sprinting is in the pool or on a bike or on a rowing machine or on land, and making sure the form and the mechanics and the warm up and the cool down. But it seems that doing this for 20 seconds where you're at 90% or 100%, if it's safe for you, seems to activate, again, a different part of our metabolism that I think is really important for metabolism and insulin resistance. So bottom line, there is a lot of research going on in exercise, in the exercise physiology arena, and how it relates to cancer outcomes. And I think that's really one of the exciting areas of cancer supportive care is the great work that people are doing and really teasing out, rather than just saying exercise, who should be doing interval training, sprinting, weight training, balance work, the combination, how much of each. I think there's going to be much more guidance in the coming year.
Yeah, thank you. I think a lot of us tend to kind of have a bit of fear with strength training, right? We think of, lifting weights as something you have to do with big, heavy weights. And, I love, I have 2-pound weights, 3-pound weights. I, try to do different ones, but sometimes, even those resistance bands, right? Or like you were saying, just using your body weight, like squats. And I mean, my least favorite friend, burpees and bear crawls, right? All of those are helping to strengthen that muscle mass and helping with all that. So thank you for talking about that. And I know we're close to the end, but I wanted to squeeze in this one last question for you, Dr. Asher. And this one says, can you speak to the difference, if any, between depression and anxiety as a response to the cancer diagnosis versus driven by metabolic flooding in the brain due to chemotherapy?
So that's a great question. I don't think I'm going to have an easy answer, but one of the things that has been hypothesized for some time is the chemotherapy triggers an inflammatory response, things like IL-1, IL-16, F-alpha. And if you think about, for example, the anecdote I often share is if you think about how any one of us feel when you have the flu, right? If you think about it, most of us when we have the flu, not only are we tired and a little foggy, but we're kind of sad or blue and depressed, at least for those few days. And it's not the flu virus that makes you feel so crummy and sad. It's your body's inflammatory response, right? IL-1, IL-16, F-alpha, these inflammatory compounds that can cross the blood-brain barrier, get into our brains and contribute to those symptoms of depression. And I believe that may be an important factor for a subset of our patients, that they have this, this inflammatory response magnified due to their treatment. And again, one of the reasons, that I think exercise can help, not only help with fatigue, but help with depression and anxiety, is because it can reduce those inflammatory cytokines. When your muscles contract, it produces these things called myokines, which then reduce the inflammatory cytokines. And again, I'm not saying that there's not a role for medications, but I've seen it over and over again. When you get someone more fit, symptoms of depression, anxiety, and self-efficacy, as we talked about, all improve as well, usually.
Well, thank you so much, Dr. Asher, for that wonderful information. And I know it's a nice little reminder for me to get moving today. I have not taken my dog for a walk today, being here at the farm, but she will get walked later today, and so will I. So thank you for that wonderful information. And I want to thank all of our panelists today and our speakers. I want to thank Bill Kavanaugh. I want to thank Dr. Jennifer Kelly and Dr. Shannon LaCava. I also want to thank our roundtable panelists. I want to thank Sylvia Lopez, Dr. Shannon LaCava, Rhonda Smith, and Gisemi Lopez, and as well as Dr. Whitaker for joining us today, and our speaker, Dr. Asher. And we hope that you all learned something new today and, are going to take this into, now we're building this awareness for you that you're learning all of these things, and we hope you take them to action and, put them into practice in the future. And we hope you join us tomorrow. Please join us tomorrow. We will be here for day 2, bright and early at 9 a.m. And we have another wonderful roster of speakers waiting for us tomorrow and another roundtable. So thank you for joining day 1. And, again, be on the lookout for that email for those of you who wanted CE units. And then we hope to see you all again tomorrow. Thank you all very much and have a wonderful afternoon. And don't forget to move, like Dr. Asher was telling us. Move a little today. Thank you, everyone.
Thank you very much.